if you ask for what are the optimal and safe targets for LDL levels for high risk ASCVD patients, the level which is given by the guidelines are less than 55 for the patient who has already had an ACS or a CCS with intervention. And if they come under very high risk, then the LDL levels target is around less than 30. And so, how low can we go or lowering LDL and mortality benefit? Definitely lower the LDL, better the mortality benefit. And how low can we go? It can even reach to a single digit levels also. So patients who comes under very high risk, they have to be kept at least under less than 30. And if it's you can lower it to less in single digit values like less than 10 also, it can be still fine and the patients won't have much side effects. Next slide. So, in most of the studies, it is well proven that the Indians have higher CV risk and experience much earlier CV events. So, elevated LDL levels are crucial due to their strong and linear association with cardiovascular diseases. So, each 1 millimole reduction in LDL is associated with 21% reduction in major cardiovascular events. So the latest guidelines recommend nowadays are you have to strike the patients as early as possible and strike strong. It means that you have to give for higher intensity statins as early as possible in the index event and as high dose as possible and reach the targets as early as possible. Whether with a single dose, single medication like statins or maybe with a double or a triple combination. So there are various guidelines which give the targets for LDL. So the most of the targets, if you see, it will be around less than 55. And patients who come under very high risk or even having extremely high risk, all these patients has to have an LDL of less than 30 or less than even 15. So there is no significant association between very low LDL levels and safety outcomes. So the target needs to be less than 30 or 55. It doesn't mean that you have to reach a target of 5 or 10 like that. So it doesn't make much a difference in the safety outcomes or mortality benefits. So inclisiran is a drug which is a small RNA inhibiting drug which reduces the LDL levels by inhibiting PCSK metabolism. So this is mostly indicated in patients who are not tolerating to statins or not reaching the LDL targets even after giving all the triple therapy. So these patients, and in case of heterozygous hypercholesterolemia or hyperlipidemia, mostly in homozygous it doesn't work much. As far as my personal opinion is, but in most of the heterozygous, it works very nicely, and the frequency of medication is very low, just 6 months once. So the patients are very compliant also. So where does inclisiran fit into dyslipidemia management? As I already mentioned, patients who are not tolerating statins or not reaching the targets in spite of giving double or triple therapy, and the patients who are having heterozygous hypercholesterolemia, all these patients would benefit with inclisiran. And patients who have multiple events, in spite of having almost borderline lipid, all these patients will benefit from inclisiran. So this is the first in class small RNA therapy to lower LDL levels. So specifically mimics the body's process of RNA interference, which is restricted to the cytoplasm, and conjugated with GalNAc for specific uptake by hepatocytes. So lower likelihood of target binding. So the inclisiran plasma levels decline within 24 hours and are undetectable within 48 hours. So Indian approval of CDSCO approved indication are inclisiran is indicated in adults with hypercholesterolemia, heterozygous, familial or non-familial and mixed dyslipidemia. And in combination with therapy, statins with other lower lipid lowering therapy, where the patients are not able to reach LDL goals, alone or in combination with other lipid therapy in patients who are statin intolerant. So inclisiran is suitable for patients who come under high risk of CVD where their LDL levels are not attained or inadequately attained, and or patients who don't tolerate statins or triple therapy, and also in patients who have heterozygous familial hypercholesterolemia. So the recommended dose is 284 milligrams of inclisiran administered as a single subcutaneous injection initially, then at 90 days, and then followed every 6 months once. So it is already a pre-filled injection. So any missed dose, if a planned dose is missed by less than 3 months, inclisiran should be administered and dosing continue according to the patient's original schedule. But if it is more than 3 months missed, a new dose should be given initially, and then again it has to be given as we have started the medication. So according to the CSI guidelines 2023, patients who are not reaching the LDL targets of less than 55, in spite of giving the triple therapy or dual therapy, are indicated for PCSK9 inhibitors such as inclisiran. So the CSI guidelines recommend that in patients with ACS, if an LDL target of 55 is not achieved with high intensity or triple therapy, and PCSK9 inhibitor is indicated. So even the NICE guidelines recommend inclisiran for heterozygous familial hypercholesterolemia, and as well as in secondary prevention for patients who don't tolerate statins or who don't attain LDL targets even after giving triple therapy. So the ACC expert panel also again tells the same flowchart where initially step by step increasing the LDL, lowering therapy of statins, then introducing with bempedoic acid or estimib. In spite of giving all these triple therapy, the patient still has higher risk of developing MACE or not reaching the LDL targets. Then these patients has to be given inclisiran. So inclisiran clinical insights, understanding pivotal phase 3 trials. So there are already old trials of Orion. Now this is the Orion 9, 10, and 11, where the status is completed, and it is in various patients like in cardiovascular risk patients as well as in heterozygous familial hypercholesterolemia patients, where inclisiran was given 284 with matching with the placebo. So there is a sustained reduction of LDL by 50%, and there is effective reduction of LDL by 50% in patients who are given inclisiran, and the lowering is much faster and more sustained. So even in Asian patients, they have found out the same result, that ratio of LPA to baseline was approximately 41% lower than the placebo at either. So inclisiran reduces not only the LDL but also the LPA levels. So inclisiran reduction levels of other atherogenic materials such as the LDL lipoprotein A levels, as well as ApoB and triglyceride levels, everything, and even the total cholesterol, everything is reduced, and it increases the HDL by 7%. Inclisiran was generally well tolerated with a safety profile similar to placebo because it is well targeted, and there are no other side effects in most of the cases, except for any allergy if the patient is allergic to the injection or the preservative. So well tolerated usually the studies which were given till 7 years they have followed up the patients and they did not have any significant side effect. So inclisiran is very specific and acts in the cytoplasm of hepatocytes and not in the nucleus. So there is no risk of carcinogenicity or immunogenicity. So the results of Orion 8, the largest long-term safety and efficacy trial with inclisiran conducted to date shows inclisiran could reduce LDL levels in long term while being well tolerated. So inclisiran cardiovascular outcome data. So the Orion, Victorian are the ongoing trials with completion of data. So the results are anticipated in 2026 or 27. And while the results of COTs are ongoing, a recent published pooled patient level analysis of Orion 9, 10, and 11 provided some insights into the possible cardiovascular benefit of treatment of inclisiran. There was a significant reduction, that is 26% reduction in the composite MACE compared to the placebo over 18 months and fewer MACE compared with the placebo.